Hey guys, welcome to the ultimate NCLEX bootcamp explainer for neurology drugs. Look, I totally get it. Neuropharmacology can feel completely overwhelming. But trust me, you've got this. We're going to break down these high-yield facts together, step by step, keeping the words simple and the concepts clear. Let's get ready to crush it. Here's our game plan for today. We're tackling seizures, Parkinson's, Alzheimer's, and muscle relaxants, hitting the exact meds, interventions, and side effects you absolutely need to know for the exam. All right, Section 1, Seizures, Meds, and MCQs. We're kicking things off with seizure medications. Now, when you're staring down anti-epileptic drugs on the NCLEX, patient safety and therapeutic drug levels are your absolute top priorities. Notice how every single drug here has a very specific red flag. Take phenytoin. It's famous for causing gingival hyperplasia, which just means swollen gums. So you gotta always remind your patients about daily oral care and dentist visits. Moving on to levetiracetam, you are watching closely for sleepiness and extreme mood changes, especially suicidal thoughts. Then there's carbamazepine. This one suppresses the bone marrow, so grab a baseline CBC to check for aplastic anemia, and definitely tell them to completely avoid grapefruit juice. No grapefruit. And valproic acid? Man, it is tough on the stomach and the liver. The big rule here, never ever mix the oral dose with carbonated beverages. So what does this all mean in an actual emergency? Well, when a patient hits status epilepticus, it is a massive, life-threatening situation because the seizures literally just won't stop. Step 1, always secure their safety in their airway. But your immediate medical move right after that is pushing IV benzos, like lorazepam or diazepam. You have to stop that continuous seizure fast. Let's lock this in with 5 hard questions straight from the source material. Seriously, pause the explainer right here if you need to read through these carefully. Look at question 1. It highlights that IV phenytoin must be mixed with normal saline. Why? To prevent the drug from crystallizing in the IV line. Yikes. And question 2, it shows a toxic phenytoin level of 35, which causes ataxia, basically a total loss of body control. The trick to these questions is just matching the exact side effect or rule straight to the drug. Okay, let's keep moving. Section 2, Parkinson's, Meds and Interventions. Let's see how all this builds into Parkinson's disease. Parkinson's is basically this really tricky balancing act in the brain. You've got not enough dopamine and way too much acetylcholine. To fix that, we're trying to either replace dopamine or stop the body from breaking it down. Levodopa-carbidopa is your heavy hitter, but watch out because it causes huge blood pressure drops. You have to assist these patients when they walk. Then we have selegiline. It keeps dopamine around longer, but it's going to cause insomnia. And oh, check out entacapone. You've absolutely got to warn your patient that it's going to turn their urine a wild brownish-orange color. It's totally harmless, but man, it will definitely freak them out if they don't know it's coming. Finally, benztropine blocks acetylcholine, which dries everything out. Just give them some sugarless gum for that dry mouth, and you're good to go. And this brings us to a huge point. Diet is absolutely everything with Parkinson's meds. Seriously, if your patient eats a giant steak, that high-protein meal is literally going to block their levodopa from being absorbed. Bad news. If they're on selegiline, they must avoid foods high in tyramine, think aged cheese and wine. Otherwise, they risk a massive blood pressure spike called the cheese effect. And for entacapone, timing is everything. They have to take it exactly on time, usually with a snack, to keep the drug from wearing off too soon and to avoid GI upset. Time to test yourself. Here are 5 application questions for Parkinson's. Drill these into your memory, guys, because the NCLEX loves testing you on these exact dietary interactions. Check out question 3. Entacapone is awesome because it reduces the on-off effect. That means it helps the main drug, levodopa, work smoothly all day long instead of suddenly just quitting. Go ahead and pause the explainer to read through the rest of these rationales. All right, take a quick mental breather right here, shake out those shoulders, and hey, while you're at it, make sure to like and subscribe to the Nurse Crush It YouTube channel for more high-yield reviews just like this one. Ready for Module 3? Section 3, Alzheimer's, donepezil, and MCQs. We're tackling Alzheimer's disease next. Specifically, we need to talk about the realistic expectations you have to set when dealing with cholinergic therapy. The main drug here is donepezil. And here's the tough reality you have to teach families. Donepezil is a management tool. It is not a cure. It doesn't fix the brain. It just kind of slows down the memory loss. And get this, it takes up to 6 weeks of taking it every single day just to see if the symptoms even stabilize. Because it boosts acetylcholine, it brings on those rest and digest side effects. We're talking GI upset, drowsiness, dizziness, and urinary retention. Always check those baseline urinary patterns. Let's test your knowledge with 5 really tough cholinergic questions. Question 3 is a massive one. A cholinergic crisis means there is way too much acetylcholine in the system. The patient's going to have trouble breathing, low blood pressure, and they might even pass out. So what do? Well, question 5 gives you the lifesaver. You've got to remember that atropine sulfate is your emergency antidote. It's the absolute go-to to reverse that severe cholinergic overdose.
All right, home stretch. Section 4, muscle relaxants, side effects.
We are rounding the corner, focusing on muscle relaxants and one major life-threatening surgical emergency. You absolutely have to know the difference between central and direct-acting relaxants. Baclofen, that works centrally, right up in the brain. And because it works in the central nervous system, it's going to cause heavy sedation and drowsiness. Dantrolene, on the other hand, is totally different. It works directly on the skeletal muscle itself. And dantrolene is your absolute direct-acting lifesaver for a terrifying condition called malignant hyperthermia.
Check out the details for dantrolene sodium here. Under the indications, you'll see it is specifically used for malignant hyperthermia in both kids and adults. So what is that? Malignant hyperthermia is a deadly hypermetabolic reaction to general anesthesia. The patient's temperature literally skyrockets, and their muscles go completely rigid. Pushing dantrolene is what stops that intense muscle rigidity. Here is your final set of 5 questions. I really want you to pay close attention to question 2. You've got to recognize that rapid rise in heart rate, breathing, and muscle rigidity. That combo screams malignant hyperthermia. Also, take a look at question 4. This is wild, but sometimes older adults get a paradoxical reaction to older sedatives like barbiturates. Basically, instead of falling asleep like they're supposed to, they stay wide awake and get super agitated. Let's wrap this all up with a quick critical thinking puzzle. Say your older patient living alone suddenly wants to start taking over-the-counter ginkgo biloba to protect their memory. What are you hunting for? Well, you have to assess every single other medication they're taking. Never assume an over-the-counter herb is totally safe just because it's natural. Which leaves us with a critical question to carry into your clinical practice. If a seemingly harmless leaf can completely unravel a complex neurological treatment plan, what other hidden over-the-counter dangers are quietly lurking in your next patient's medication list? Think about that, keep studying hard, and I'll see you guys in the next explainer.